Good evening. Welcome, everybody. Thank you for joining. For those of you who don't know me, I'm Tracy Milgram Posner, the founder of BRCA Strong, where we empower, inspire, educate, and advocate survivors, and thrivers to eliminate the feeling of isolation and help you feel whole again. Due to COVID-19, we are not having any in-person events. Everything for 2021 will be via Zoom. And our programs still continue as we are sending out care packages to women who were just diagnosed with breast cancer or who found out they carry a gene, starting treatment, or who are going through treatment. So if you or a family member need a package, you can feel free to reach out to me at any time, or Kate, my board member who's on the call. Tonight, we have a special guest, Dr. Lora Wang, who is going to speak about radiation oncology. And before we pass over the mic to Dr. Wang, what I'd like to do is to take a second for everybody to do about a 20-second introduction, just of who you are, just so we're all in a safe zone and feeling comfortable. I feel that it's very important. And if there's anybody that does not want to speak, you can just let me know ahead. But just so our voices stand out when we ask questions, we're all comfortable. So Kathy, if you don't mind to start, that would be awesome.
There we go. I'm Kathy Baker, and I am a breast and fallopian tube ovarian cancer survivor, and I'm BRCA1 positive, BRCA1 mutation, and I'm the founder of an organization that is seeking to help people, encouraging people and giving information and assistance with genetic testing. And it's called My Faulty Gene.
Perfect. Thank you, Kathy. Mm-hmm. Jacqueline?
Can you hear me?
Yes.
Can you hear me?
Yes.
Okay. I had a lumpectomy almost a year ago, and my mother had breast cancer at 89. Her mother had breast cancer a long time ago. And nobody thought to do the genetic testing until I was already through the radiation. But I'm interested in the talk tonight because I have some surgery coming up, but I definitely have side effects from the radiation, including shingles right afterwards. And now I have lymphedema in the area, of course, the scar tissue. So I heard you say earlier when I first came on, getting information, it's been quite a challenge. I've had to do almost all my own research right down to finding them physicians. So it's been a challenge.
Well, thank you for coming first, I'd like to say, and if there's any help that we can help you with and guide you through any physicians, we are national, work with several physicians all over the world. So if you ever have any problems, you can feel free to reach out to myself and I'd love to help you.
Okay, thank you.
Perfect, you're welcome. Monica?
Hi, everyone. I'm Monica Cejas. I was diagnosed in October. Breast cancer is not new to my family. My mom actually passed away 15 years ago when I was 6 months pregnant with my daughter from breast cancer. I saw the effects of chemo and radiation on her, and I think that's what has scared me so much. I know technology is very different. I want to learn what Dr. Wang has to tell us about radiation and combating the burns and potential side effects. I did have already a central lumpectomy, and I began chemo already. I already had 2 sessions of AC. I have ACT sessions, and then I'll have 33 of radiation. I did have 1 lymph node positive as well, so they're going to radiate the breast and I guess the lymph nodes. I did recently do the BRCA analysis, and thank God I was very fortunate it was negative. So I was mostly fearing for my daughter, thinking that since my mom had it and I have it, that, I can pass it on. So hopefully it's just, back to 1 in 8 for her, hopefully, and not that we carry the gene, but you never know. There's so many things that happen every day and new genes that we're finding these days, but obviously finding things early is key, and you guys are doing an amazing job informing us and teaching us and holding our hands through this whole process. And thank you so much for for being there for us.
You're welcome. And if there's anything we can help you with, let me know. I know you're in Miami, so you're local. So if there's anything that you need, just let me know. I'd be more than happy to help you.
Thank you.
You're welcome. Danielle?
Hi, my name is Danielle Lustig, and I was diagnosed with HER2 positive breast cancer in July. I started with chemo, and the tumor was continuing to grow. So we halfway through it stopped and had me have a mastectomy and lymph node removal in the end of September. And now I'm on TCHP for 6 sessions, which is the chemo. And we'll then, after a brief break, have radiation to sum it up. So, so similar to Monica, interested in hearing all of the, things to know about what to expect with radiation, and what to look for, and what maybe we can do to help make it a smooth experience.
Perfect. Well, thank you for joining.
Sure, thank you.
Kelly?
Hi, good evening. My name's Kelly J. Bush. I was diagnosed with ER/PR positive HER2 negative breast cancer at age 43 in September 2018. So I went through 4 dose dense AC and 4 dose dense Taxol and 28 radiation treatments and a bilateral mastectomy and axillary lymph node dissection. So I'm still dealing with a lot of the after effects from that, with lymphedema and a lot of, tightness in the chest and underarm area after all those treatments. So I'm looking forward to learning how to manage some of those side effects.
Perfect. Well, thank you for joining. It's nice
Thank
meeting
you.
Kate?
Hi, I'm Kate. I'm part of BRCA Strong. I'm a provider as of 2 years. And I'm just here to listen in and be there for all of you guys.
Thank you, Kate. Gina, if you don't mind, I know you just joined us. If you don't mind, just to do a short introduction, and then we're going to go ahead and get started. Okay, Dr. Wang, so if you want to go ahead, you could start to screen share.
Okay, perfect. I'm going to share my screen right now.
Thank you so much again for coming on and taking your time to educate our community. As obviously, if you've heard, there's not a lot of information out there on specialists, so we really appreciate you coming on and taking your time to do this.
Oh, you're very welcome. And thank you so much for having me. I really, enjoy doing talks like this. I think there really is a lot of information out there, and a lot of information that's out there is, not quite accurate. So I think it's a good opportunity to be able to share this with, people that I don't meet face to face in a consult. But thank you to Tracy and to BRCA Strong for having me here. It's really like an honor and a privilege. So I am going to talk about the sort of generally what to expect from radiation in terms of the side effects, both the side effects that happen during radiation, which we generally say are temporary and will go away with some few exceptions, and the side effects that can happen months to years later. Again, my name is Lora Wang. I am a radiation oncologist specializing in breast cancer at the University of Miami. So just some general information about breast cancer. I'll try to breeze through this because I'm sure you all know this information, but breast cancer is the most commonly diagnosed cancer in women in the United States and the second most common cause of cancer death in women. The lifetime risk of being diagnosed with breast cancer is approximately 1 in 8. And, actually most women who are diagnosed with breast cancer don't have a family history, but 5 to 10% are due to genetic abnormalities such as BRCA. This is the screening recommendations for lots of different organizations, but generally we recommend screening starting at age 40 for no family history and no genetic abnormalities, and with annual mammograms. If someone has a BRCA gene, for example, the age of screening, generally we recommend starting at age 25 and with an MRI, and then adding a mammogram at age 30. So alternating an MRI and mammogram. This is just, a general picture of the breast. So the lobules are where the milk is produced, and then the ducts are how the milk is brought to the nipple. And at the very end, these are called terminal ductal lobule units. And what lines these cells, or what lines everything, is called epithelial cells or luminal cells. And this is generally where the breast cancer starts. This is very quickly just going through the staging. We separate staging to 3 parts. So the T staging, so how big it is in the breast. The N staging, so the number of lymph nodes involved, if any, and then the M staging, so if the breast cancer has gone outside of the breast and lymph nodes. So in terms of the T staging, so what it looks like inside the breast, it's mostly by size. So the smaller it is, the earlier the T staging, and the bigger it is, and the more things involved, the higher the staging. And it goes from T1 to T4. And in terms of lymph nodes, it depends on whether you have lymph nodes involved or not. And the most common area of lymph node involvement is, as everyone knows, in the armpit here. So again, mostly by the number of lymph nodes, but also by location of lymph nodes. And then finally, the M staging is whether the cancer is only in the breast and or lymph nodes, or if it's outside of those areas. And if it, God forbid, it is outside of those areas, that's what we would call metastatic disease. I put this here not to really be comprehensive, but just really not to really go over this, but just to sort of give an idea of how the staging is grouped. We generally group the tumor by how big it is in the breast, if there are lymph nodes involved, and if the cancer has gone outside of the breast and lymph nodes. But in the most recent edition, this also takes into account the hormone receptors. So, do you have hormone receptors positive? Is the HER2 positive? What's the grade of the cancer? And then all of those things actually puts you in different groups. Okay, so I just wanted to sort of breeze through that, but I want to focus more on the radiation and what are the indications for radiation. So generally speaking, early breast cancer, if someone has a lumpectomy, then radiation is the standard of care to complete breast conservation therapy. Radiation does reduce the risk of breast cancer from coming back by about 50 to 80%. And while this is a standard of care for a very select group of patients, and generally these are patients who are older, and by older I mean 70 or older than that, who have very small hormone positive receptor or hormone receptor positive cancers, and their cancer has been fully excised. For some of those women, it might be an option to not do radiation, but it is a conversation about the risks and benefits. And after a mastectomy, generally, we consider radiation if the tumor is large, which is, we consider it to be more than 5 centimeters, or if there is a lymph node that's positive. Again, this is a conversation about sort of what the risks and benefits are, but it would say many times it is recommended. So some basics about radiation. Radiation is a local treatment. It is a daily treatment, and that is given Monday through Friday. And generally it takes about 15 to 30 minutes a day. And that is what it is for us. And this is the an example of a radiation machine. So this would be what we would call the table. So it's something that women would lay on, and then this machine would essentially move around and deliver the radiation. So at least at the University of Miami, for us after lumpectomy, generally the recommended time for radiation is 3 to 4 weeks. And then after a mastectomy, we generally recommend 5 to 6 weeks unless they're on a clinical trial. I wanted to give an idea what the radiation would look like. So before we start the radiation, everybody needs a CT scan, and they need to be put in the position that they're going to get their radiation. And the reason for that is that radiation, like we talked about before, is a local treatment. It's only going to go where we point it. So it's extremely important to have a picture of your body, so we can correctly tell the machine, this is where the radiation needs to go and this is where it needs to not go. And so the CT scan beforehand acts to give us that picture. In addition, we also put you in the position where you will get the radiation, and you will notice that the arms are up. And I will say that after surgery, sometimes this is difficult, especially after an axillary lymph node dissection, because the arm can be very tight. And then often after the surgery, the arm is maybe only going up to 90 degrees at some point. So we always encourage patients to do exercises because we cannot start radiation. I'm sorry, my arm is like floating, until the arm is able to go fully up. This position here where someone is laying on their back is generally the position we do the radiation in. For some patients, excuse me. Oh, excuse me. Thank you. For some patients that we treat the breasts only, it is possible to treat them laying down. As you can see, for women who have sort of larger breasts that are more sort of soft and pendulous, it actually tends to be a very good position for them to be in because the breast is able to fall forward, sort of away from the body, therefore minimizing the amount of normal tissue the radiation touches. But it is not a good option for everyone. Again, we generally use this for treating breast only, so no lymph nodes. And also, if the breast size is small, it doesn't really help. Not to mention, this is typically an uncomfortable position to be in. Generally, people much prefer laying on their backs. So laying on their stomach with one, you're laying on one, so you can't see, but she's laying on her other side, and this side is essentially hanging down this hole. I want to go over some common breast radiation misconceptions. These are things I hear often from patients, and these are all not true. So being bedbound during radiation, being radioactive, that radiation will make you immunocompromised, or that you will lose your hair. The only so you certainly will not lose the hair on your head. So after chemo, often the hair will continue to grow during radiation. Some women, if we do have to treat the lymph nodes, can lose the hair temporarily in their armpit, but usually I don't hear complaints about that. But again, it is also temporary. So I want to share this study with everyone, but basically it's a study which surveyed breast cancer patients who were treated at UCLA, and this was published in 2018. I think they surveyed some 500 patients who were treated between a certain time period, and 300 and some patients returned the survey. But for those who returned the survey, most patients had little or no prior knowledge of radiation. About half the patients had either read or had heard frightening stories about this serious, I'm sorry for the typo, radiation side effects that they expected. And then, here's a list of the top ranked fears, the number one being damage to internal organs. And even though this damage to immune system is relatively low in this study, to keep in mind that this is the pre-COVID time. And I will tell you from at least anecdotal experience that this is a very common question I get from patients. So after radiation, about 85% of patients actually found their actual radiation experience to be less scary than originally expected. And I would say most of the lumpectomy patients, and slightly less, but still most of the mastectomy patients, found the statement that if future patients knew the real truth about radiation therapy, they would be less scared about treatment to be true. So here are some of the changes that can happen during radiation therapy. Again, these are what we would consider acute changes, and most of these are going to be temporary with some exceptions, and they're going to happen a little at a time during radiation. They will go away with time, but it will take some time, but they will happen a little at a time as well. So after the first radiation, you're not going to feel any differently than you felt before going into radiation. So some of the things that can happen are breast and skin changes, meaning, the breast can be more swollen. It can, especially at the site of the lumpectomy or the mastectomy, you can get these pinprick sensations, which is common after surgery, but can improve with time, but can increase during radiation. And again, afterwards will improve. Skin changes being things like getting red, dry, itchy, can get darker. So tanning is actually one of the things that can be permanent after radiation, and we'll talk a little bit more about that. And then towards the end, for some people, their skin is going to peel. So even though you will not be bedbound during radiation, you will certainly feel tired. What I generally tell people is that imagine what they're doing for 3 to 4 weeks or 5 to 6 weeks, depending on the length of your radiation, is all they're doing for that period of time is driving to the hospital, parking their car, sitting there for 30 minutes, going back to their car, and then driving back home or going to work or whatever it is they were going to do. If you did that for 3 to 5, 6 weeks, you're certainly going to feel tired just from that. But the radiation will certainly contribute, and it can make people tired. Many people do continue to work full time during radiation, but towards the end, you might need to take, some time off, or sleep earlier or at night if possible, or take a nap during the day, especially on the weekends if possible. And if you need radiation to the lymph nodes, some people can get some throat pain towards the end. So the throat pain would not be in the mouth or not in the back of the mouth. It would be sort of down here where the collarbone is, because the lymph nodes that get radiation is very close to the throat. And so sometimes the lymph nodes in the low neck do get radiation if radiation to the lymph nodes are needed. So towards the end, people can feel like food that's going down, they can feel it going down, so may need to change the diet to something softer, or occasionally someone would need to take like some Tylenol or Advil before eating. Again, all the side effects happen a little at a time and generally take 1 to 2 weeks to start noticing any changes. But I mean, this is just a general guideline. Some people, sort of breeze through the radiation. Some people can start feeling the changes relatively early. So it is difficult to say for sure, but again, some general guidelines. So I wanted to show some pictures of, I thought maybe that would be relatively helpful, of patients who have gotten radiation. This is by no means comprehensive, and I actually, I left out some pictures because I didn't have a chance to upload them. But This is 2 patients who are about 2 weeks into radiation. And so both of them were getting radiation to the left breast. And then as you can see that, if you sort of look closely, the left breast is certainly slightly more pink compared to the right, but it's really not super noticeable. And the redness here on this patient and here is because she actually was treated with her laying on her stomach. So this is, the mark from laying on the right side and also the mark from the board itself. So here are some examples of patients who were treated 3 to 4 weeks after 3 to 4 weeks of radiation. So generally what we have been doing for patients who only need breast treatment or who have had a mastectomy but no implant, we do 3 to 4 weeks of radiation total. So for all of these patients, this was at the end of their treatment. So as you can see, this patient, the skin is darker compared to the other side, and the breast was slightly more swollen, but it was not significantly different. And you can see the skin has not peeled. And this is actually the patient from the prior image. And you can see that, yes, it is more pink. Again, I think maybe these pictures are not fantastic, but there are changes compared to the other side, but it is mild. And then for this patient who had a mastectomy, you can see that especially in the armpit, it is darker, and that is a common area. We see that the skin will change the most. A part of that's just due to the constant rubbing that happens, because our arm is always moving. But it is not, it certainly is darker compared to the rest of her body, but it's mild. This is a patient who had, more generous breasts, and you can see that this side is darker and slightly red compared to the other side. And I had her show what, under her breast, because actually this area here where the breast sort of folds on itself and the armpit, these are both areas, because of the constant rubbing that happens anyways, can get more irritated during radiation compared to the other parts. So if you can imagine, if you had, say, like a scrape on the hand and you were constantly rubbing at it, that's sort of the equivalent of what's happening sort of underneath the breast and in the armpits, because naturally that's happening all the time. So this is 1 month after radiation. And I chose these pictures mostly because I can show you the pictures of patients who actually don't have very many changes. And we see that maybe about 50% of the time that people do quite well. But I want to show you some things that could happen, that first visit, I have a visit 1 month after radiation, and this is what people can look like. So for this patient, you can see the breast is darker compared to the other side. Again, this is something that is common during radiation, so tanning of this one side compared to the other. And for some people, this can, or at least some component of it can be forever. There is really difficult to tell actually who's gonna get what. But I would say, generally speaking, the more fair the skin tone is, the less likely there will be sort of long-term tanning. But again, this is sort of just anecdotal, and it's difficult to say for sure on a person-to-person basis. But when I saw her 3 months after this, the two sides were almost, you could barely tell the difference. This was actually this patient here. You can see that from at the very end of radiation and 1 month after, it looks significantly different. And I want to show this picture because this is something I often tell patients, which is that the worst changes can actually happen 1 to 2 weeks after radiation is done. And so to be prepared for that, or at least not be shocked if it does happen, we generally give you all the instructions you need to go home with and to prepare. But just to show you, all of this darker skin is actually just dry skin, dry dead skin that's going to come off. None of it really peeled like I guess, when I think of peeling from a sunburn, I think like that red, angry peeling, which everyone generally thinks of. This is sort of like, that didn't really happen. It did get a little irritated, but because it got irritated from the radiation, the skin is just going to come off. And it just hasn't yet. It's just dry skin. She was extremely careful in this area and sort of just like washed it very gently with water. So this was just a lot of dry skin that was going to come off very quickly after this. Another thing I do tell patients is that, our skin is constantly coming off and dying and changing all the time. And that's true for everyone. But what happens with radiation is that all of that skin is getting irritated all at the same time. And so it's going to come off sort of all around the same time. And so that can be very concerning for people, for obvious reasons. But for many people, it's going to be this dry peeling. So it's not going to be, angry or open underneath, but it's just sort of flaking off and the new skin underneath is already there. And then this patient, again, compared to the other side, this side is certainly more tan, but I want to show you that she had this scar in this area where she had this infection after surgery that had to be drained and then ultimately opened. And as a result, because the rest of her scar is actually around the nipple, as a result, this area was irritated for months before we started radiation. And just keeping in mind that areas that were previously irritated can become more irritated after radiation. And you can see this area has more noticeable changes compared to the rest of her breast. So I want to show some popular items used. These are some of the things that we recommend for women to use. If you're using lotion, again, we're in Miami, so in the summer, aloe tends to be extremely popular, and it becomes summer very soon. So, and it's really nice because what people do, and again, you can use, normal, like the plant aloe, it doesn't really matter. But aloe is quite nice because you can put it in the fridge. And so people tend to like it because it feels cool against the skin. One of the things that I like that I know a lot of dermatologists recommend is Aquaphor. It is very, very moisturizing and it sort of can keep, lock in some of that moisture that gets lost as the skin gets irritated with radiation. I just want to counsel that none of these things that we recommend is going to prevent changes from happening from the radiation itself. But what it's going to do is help protect the skin and avoid adding additional irritation on top of it. And that's actually going to help, because if we just sort of left it alone with the clothes that we're wearing, with the constant movement as the skin dries out, all of that's going to, the radiation irritation is sort of just going to compound, and that's all going to make it worse. Another one of my favorites that I personally like to recommend is this thing called the Cavalon spray. Again, I want to make clear that, we don't endorse any products whatsoever, that these are just things that we recommend for patients if they're interested to help with changes during radiation. But this is a spray that's we recommend that people use on the area of concern, either, post mastectomy or their breast, every 2 to 3 days. So you spray once every 2 to 3 days. And while you're using the spray, we ask that you do not use any other ointments or creams or lotions during that time. Because what the spray is really doing is it's creating this very thin layer of I mean, it's essentially just creating this a barrier, essentially. It's adding another layer on top of the skin. And the benefit is that it's going to prevent the skin from rubbing against things on a daily basis. So there have been some studies that have been done which have shown that it is better, or that there are less skin changes as a result. Again, you're sort of preventing that rubbing. We recommend it early on. Some people use it the entire time they get radiation, but if the skin does get more irritated, then we do recommend that they stop using that and start using lotion instead, just so you can moisturize the skin. Because while using the spray, we ask you don't put any sort of lotions or creams on, because they'll create this gunk with the spray, and then it actually is counterproductive. But again, these are some of the things we recommend. But I tell patients, if you have something on hand that is gentle, doesn't have fragrance, that's like mostly water-based, you feel free to use that. You don't have to go out to buy anything special. So some of the long-term side effects, again, I did hear your concerns as you were introducing yourselves, and I apologize. I mostly focused this talk for patients who are getting radiation to the breast only, and less for patients who are post-mastectomy or need lymph node radiation. But I'll try to cover as much as I can. But in terms of the long-term side effects, for women, like I said, for some women, the treated side will forever be more tan than the non-treated side. It's hard to estimate how many patients will notice a difference at all. I mean, my best guesstimate is that it is more than 50%, but it's certainly not close to 100%. So something, slightly north of 50% is really my best guesstimate. But of the women who do have a tan compared to the other side, for most women, it is very, very mild. So it's something that you would have to really look closely at, or, know. But for some women, it can be more pronounced. And the treated breasts may be smaller than the other side. Again, after a lumpectomy, for many women who go straight from lumpectomy to radiation, who are not getting chemotherapy, the breast is still swollen and there's still fluid collection from the surgery. So after radiation and after all of that heals, and as the breast is less swollen and the fluid collection is reabsorbed and becomes a scar, the breast will be smaller anyways without radiation, but radiation does contribute to it a little bit. So in terms of damage to the lung, I would say that especially nowadays with modern techniques, the damage to the lung is extremely rare. On modern trials, it's something like 1 in 500 in patients who need radiation to the breast only. Excuse me. And about 1 in 100 if patients also need lymph node radiation. And this is, most commonly something called radiation pneumonitis. And briefly what that is that the body is reacting to the radiation just like if you had an infection, for example. So it's sort of reacting to the radiation, is trying to fight it off. And as a result, sort of brings in this response that you normally have to like a bacteria or a virus, even though there is none present. And what can happen is you can get a cough, shortness of breath. Some people need to be on steroids. But again, I would say uncommon. And I think, again, 1 in 100 is these numbers are more like somebody who, maybe has noticed that there might be changes on a CT or something, but potentially not somebody who's needing medication at that time. I included some plans for some patients to sort of give you an idea what it looks like, these days. For somebody who has, like I said, large soft breasts who's able to tolerate laying on their stomach, we often treat them laying down. And again, the benefit is that the breast sort of hangs down and then it sort of hangs away from the body. And you can see, so the blue line is at the very edge of the radiation. And so although it does graze the lung and the amount that the lung is getting is certainly not zero, it is a very small sliver of the lung, especially for this patient. But generally, we treat patients laying on their back. And although, I mean, compared to the other side, it looks like a lot, I can tell you that this is a very, very small amount. At the end of this rate, there's really no radiation beyond, back of this line. And so, and right here, this is the heart, and this is the heart right here. And I mean, this is only one image, but as we go up and down for this patient, we would see that the radiation does touch the heart, but ultimately it ends up being a very small amount. So as we were talking about the heart, how does this affect the heart? I would say that, sort of my best answer is that it's very difficult to quantify. And, based on our best knowledge, we do not think that there is a safe dose. So for many parts of the body, we do think that there is, a quote unquote safe dose for radiation, meaning that any amount of radiation below a certain threshold should not affect the body at all in that organ. But for the heart, we don't really know, and we, at least at this point, don't think that that's true. So we think that any amount of radiation could potentially affect the heart. So what we do is, generally we try to lower the amount of radiation as much as possible by using different techniques, different positions, and sometimes different types of radiation. Like we have at University of Miami, we do have protons. So that is one way we can do it, but we'll talk a little bit about protons, but I won't go into too much detail. And again, the increased risk to the heart, we think is probably proportional to the amount of radiation, but also proportional to whatever the baseline risk is. So for somebody who has, say, no risk factors for heart disease versus somebody who has, multiple risk factors, if they get the same amount of radiation, for the person who has multiple risk factors, to increase in the risk of heart disease later is actually going to be higher because of those risk factors. And then we think that even though there is a proportional increase, the absolute risk is likely low. There was a study looking at sort of a combination of a lot of other studies, including up to more than 1 million women who were treated with breast cancer, and the increase in coronary artery disease and cardiac death was increased, but that those numbers were 76 in 100,000 patients and 126 in 100,000 patients. So, about 1 in 1,000 or less than 1 in 1,000 in both cases. And in terms of lymphedema, and although I put this as a long-term side effect, this is certainly something that we can see that can happen during radiation. Because what's happening is that the area that's getting radiated is getting irritated. And as the body tries to fix that, what it does is it brings in fluid and brings in this sort of immune response to try to fix everything. And after an axillary dissection, what can happen is, I sort of, the analogy I use is that now there's a roadblock. So as long as, everything is flowing normally, then usually it doesn't really matter. But when you have a lot of traffic going through, so what's happening is when you bring in a lot of fluid in this area, and then, as the body is trying to fix things, then what happens is everything needs to come back to the heart eventually. And so because there is a roadblock here, it makes it harder. And that's when you can notice swelling. I want to say that on modern trials, to increase with radiation to the lymph nodes, in addition to surgery. So not the total risk, but the increase that radiation gives is about 5%, meaning, in a group of women, 5 out of 10 will get lymphedema with radiation, even though they did not have it beforehand. Again, these are sort of modern numbers. And again, these are sort of our best estimates. And then in terms of the second cancer, it's generally estimated to be less than 1 in 500, but certainly not 0. Again, we really don't know if there is like a safe amount, below some amount, you will not get cancer. At this point, we just don't know, and we assume that it is not true, so that any amount of radiation can predispose you to a second cancer caused by radiation. But again, that number is low. It's 1 in 500, but I generally do tell patients that this is a lifelong risk because, it has been reported that some people can report things up to 25 or more years after radiation. Generally for women who are young, it may not be a lifetime risk, but, 25, 40 years, or sorry, I guess there have been reports up to 40 years. So, 40 years for many people, it is a lifetime. So other treatment options include partial breast radiation, and which is an option for some women who have early breast cancers. But again, not all women. There are a lot of limitations, but if it is an option, I think it's a really great option for most women. It decreases the amount of breast tissue that gets radiation, and therefore it decreases the side effects because the area that can have side effects is going to be smaller. And another option is proton radiation. So I won't go into too much detail because I think probably that would need a talk on its own. But briefly, proton radiation is, the normal radiation we give is called photons. And I think they probably did that just to make it extra confusing for everyone. But it's essentially what we do is a high energy X-ray, and proton radiation is just a different type of particle that does the same thing. We think of the ultimate end result as being the same. So not, as far as we know now, no one radiation is better than the other. So you're not more likely to be cured as a result. But one of the potential benefits of proton radiation is that it is a larger particle, and how I try to explain to people, and this is not, I haven't been able to come up with like the best analogy, but this is sort of the best I have, which is that if you imagine a crowded beach and you are trying to hit, you're standing on one side of the beach and the ocean is the other side, and your goal is to essentially hit the people right in the middle of that beach. The X-ray or photon radiation that we normally do is like flicking a speck of sand. You're definitely going to hit those people, but some of it actually going to go into the ocean because it's so small. Whereas, with proton radiation, I try to tell people it's like throwing a beach ball or like a volleyball or something. You're again definitely going to hit those people, but you're more likely going to hit those people and not go too much further beyond that. So that's sort of the benefit of proton radiation, is it's able to touch less things around where we want it to go. But again, just the caveat is that it is not able to not touch things at all, just because that's, at least at this point, not possible. And then the last thing is that I would say most women, there is no benefit to proton. I would say for the women who have at least the most, who are most likely to benefit from proton radiation is probably going to be women who are getting their left side radiated and who need lymph nodes treated. Okay. Sorry, I've talked a lot. Thank you so much for your time, and I want to take this time to answer your questions.
Perfect. Thank you so much, Dr. Wang, for coming on, and I certainly learned a lot from this talk. So what I'd like to do is open the conversation to everybody. If you guys have questions, if you can either raise your hand or type it in the chat or just take yourself off mute. I do see that there was one chat and it's, can you see it?
Yeah, so I see a question from Kathy and it says, if I could read it out loud, I experienced a radiation-induced fibrosis. What causes this, and is there any way to reverse it? I mean, first of all, I'm really sorry to hear about that, Kathy. It's certainly a rare side effect that we do see, and I would say that unfortunately we did see it more when we were, when the technology was less sophisticated and we were able to control the radiation less. But what it is essentially, how radiation works is it damages the DNA of the cells. And as the body tries to fix that, it's coming in with, the normal things we use to fix things. Like if you had a cut on your hand, then the body's bringing in, cells to try to fix that. And essentially what it does is it lays down scar tissue as it's doing that. And what radiation-induced fibrosis is just extra scar tissue that has formed as a result of the radiation. And is there any way to reverse it? I would say that is a really complicated question. There are certainly ways to treat it in terms, there's a lot of factors that go into it, but I would say number one, physical therapy is extremely important in terms of like, massage and in terms of range of motion. The other thing is sometimes it was so some people do prescribe medication. It's essentially vitamin E and another medication called Trental. And it's you put people on for maybe 6 to 12 months to see if there's any improvement in terms of the fibrosis, to try to sort of bring sort of like antioxidants to try to fix all of that. Another thing that I'm not really a huge fan of, because I don't really think it's great in this type of setting, is some people do hyperbaric oxygen. But I that's, in case anyone doesn't know how hyperbaric oxygen works, it's like you sort of go into this huge tank, and then they put you under a lot of pressure, with high amounts of oxygen. But it is more labor intensive. It's usually like many dives. So every treatment is usually called a dive, like, if you were diving for something. And it's usually something like, 20 to 30 plus dives, and there are side effects associated with it. I'm not sure that's great for this scenario, but generally, physical therapy is going to be the thing that's going to help the best in the long term. And vitamin E and Trental, I've, tried for some patients, but it has varying results. Okay. And yes, Jacqueline, before I move on to your question, I'm going to just read a question from Kelly, which is, can you explain how radiation works on women with expanders placed after mastectomy? Is it equally as effective with expanders in? Yes, so absolutely. And again, I apologize. I didn't focus much on post-mastectomy radiation as I perhaps should have. But the expanders do not cause the radiation to be less effective. However, there are side effects associated with doing radiation with expanders in terms of how it affects the expanders themselves. I would say that the biggest issue tends to be when the expanders need to be exchanged out for permanent implants, that because you're now doing surgery in an area that has gone radiation previously, that area may be at higher risk for the wound not healing or taking a longer time to heal. And the risk is a little bit smaller when you have expanders in compared with if you had permanent implants in. But either way, after radiation, there is a risk of an increased risk of what we would call capsular contracture. And what that is that there's, and how I try to explain it is that, you want scar tissue to form around the implant and the expander to hold it in place, because without it, there's really not too much holding it in place. But as a result of the radiation, what can happen is extra scar tissue forms around the expander. Around the expander is really not a problem, but when the time of the permanent implant is placed, again, not as big of an increase of a risk versus, versus like having the permanent implant in during radiation, but there is an increased risk of having increased capsular contracture, meaning the implant itself on that side could sit, higher. It can cause some skin dimpling, for example, or at worst, again, this is rare with or without radiation, but again, radiation sort of increases the risk overall, is that it can be so severe that it can cause pain or difficulty in movement, and ultimately may need to be removed. Sorry, Jacqueline.
You may have answered this already. I'm not sure if I really understand the definition of fibrosis, but I've been told what I have is lymphedema in the left breast area where I had the radiation and the lumpectomy. They also were attempting to take the sentinel lymph node. There was no cancer in my lymph nodes, but the cluster had 7 lymph nodes in it. So, I have the compression sleeve and the compression glove, and I also have kind of like a wrap that I use around my chest area if I'm working out. I've been in physical therapy and they can get the fluid to move, but as soon as I use my arm again, it comes right back. So are we talking about the same thing? Is that what fibrosis is?
Not exactly. What you have, like you said, is definitely lymphedema, unfortunately. Um, you know, um, our heart is this muscle that is pushing the blood out everywhere. But, as it goes out to everything, there is no like little heart in our fingers or, to push the blood back. Everything's sort of coming back slowly by itself. And in the case of our arm, it's coming back against gravity. So after a surgery where it unfortunately must come back through the armpit, is that every time you use the arm, it sort of brings in fluid, because you want blood to flow there, right? As you're using it more, you want more blood to flow there. But as that happens, then sometimes what happens is, because of that roadblock that happens in the armpit, because the lymph nodes have had surgery and now there's scar tissue there instead of a road, then it has to sort of go around there, and as there's more fluid in the arm, then unfortunately that can cause swelling. But what you're doing sounds like you're doing everything correctly, which is wearing the sleeve, doing massages, doing the wraps. Occasionally, I've seen the therapists order patients like a compression machine where it's like
The pump.
yeah, the pump. And I've heard, although everyone says it's not as good as seeing a physical therapist, but that, it's quite, I would say, most people have told me that it's quite good and that they do like it and that it does help.
Okay, thank you.
Does anybody else have any questions?
I'm gonna read Monica's question.
What?
I already had a central lumpectomy on my left breast, so the tumor is already out. Will radiation be on the entire breast or near the area where the surgery occurred? So I remember you said you also had a lymph node that was positive and that they're offering both radiation to the breast and the lymph node. So in cases like this, we would not do radiation to only part of the breast. The standard would be, to the whole breast plus the lymph nodes. So unfortunately, doing it to only where the surgery is tends to, and I can't tell how old you are, but you look quite young. So generally speaking, even if you did not have a lymph node positive, that probably at 48, which is very young, we probably would not offer partial breast radiation anyways, but again, it sort of depends on the situation. How common is skin cancer after radiation? I mean, if you're talking about the normal type of skin cancer, like the ones, the dermatologist will burn off or clip off, it's usually not so common. What we're talking about in terms of second cancer after radiation is more like I mean, the most common thing we talk about is a sarcoma, which is sort of comes from the connective tissues of the breast, like the fat, the muscles, and things. And it can unfortunately occur on the skin, but it's not generally what we think of as skin cancer in terms of like the ones we get from getting too many sunburns.
Perfect. Anybody else have any other questions?
I have one question. I'm doing radiation therapy right now, and I think I'm on day 13, and I still have, they want me to do 30 sessions. Obviously I'm darker skinned, and when I finished, I did chemo before I did my surgery. My surgery went real well. I'm a T3N1. So it was relatively large, but they got clean margins on everything. And I'm just wondering, is there a percentage or a study that they've done to know if I stop doing radiation therapy now, like by the end of this week, and I say I've really just had enough already, if there's any kind of study that says, that the reoccurrence in that area would be, and then a number.
Yeah, unfortunately, Gina, I there is not. We generally think of radiation as a course. So, different than chemo, meaning, you either do it all or you don't do it. And, doing it halfway, although, we couldn't say for sure, is probably similar to not doing it in terms of what it does for the cancer itself. We generally think the reason we do a little bit every day is to try to minimize the amount of changes to our normal tissues, to give time to repair. But the cancer cells, God forbid, if there are any left over, and that's why we do the radiation, needs a certain amount in order for it to be effective. And so, generally that's the entire course of the radiation, unfortunately.
Okay. All right. Thank you.
You know what I would like to say before we hang up with Dr. Wang is, for any of you that are going through radiation and are interested in Aquaphor, please reach out to me. Just send me a DM. I was very fortunate enough that we have partnered with them for 2021, and they have sent us all of their healing lotions that we can provide to women who have radiation burns. They have a spray for if it's spots you can't reach and you're by yourself. They have a spray, and they also have their other products. I'm more than happy to send anybody who needs them a box of them. There's like 30. It'll last you a long time. We have coupons and stuff too. So if anybody's interested in the Aquaphor, just feel free to reach out to me. I'd love to send you guys some. Anything that we can do to obviously help you guys feel better, we're more than happy to do that. So with that being said, yes, go ahead, Kelly.
All right, one last question. I just wanted to ask Dr. Wang, how do radiation oncologists come up with or what determines the number of treatments you have? Like I had 28 treatments, but
so I would say that the number of treatments is relatively standard, meaning that after, depending on the area, so after a mastectomy, for example, with an implant, the standard would be something like 25 to 28. So that's about 5 to 5.5 weeks. Some people need an extra week, for example, if they do still have their breasts, or if they need an extra week for whatever reason, then it would be, 6 to 6.5 weeks after a mastectomy. At University of Miami, there is a trial looking at patients who do have expanders or implant or permanent implants in, and doing a shorter course of radiation. So instead of 28 treatments, we would do 16. So, 3 days in a week, but it's not a choice, meaning you don't get to pick what you do. It is a flip of a coin. So generally speaking, unless in that scenario, 5 to 5.5 weeks is pretty much the standard.
Okay. Thank you.
You're welcome.
Well, Dr. Wang, thank you so much for coming on and giving us so much knowledge and education, on radiation. I know, like I said before, I walked away with a lot of information and, now can pass this on to other women. So I'm very grateful for your dedication and just coming on and taking that time out to do this, to educate the women who really need it the most. So again, Raka Strong is very grateful, and we look forward to having you on in the future.
Thank you so much for having me. It was such a pleasure. I'd love to do this again. And, again, thank you again.
Perfect. Well, for those of you that want to stay on